Thanks very much. Thanks so much for joining. This is going to be a pretty informal session. I've got some information to share, but would love to also be as responsive as possible to questions. So feel free to come off camera or however you would like to interact. Appreciate everyone joining. All right, Lisa, do we have anyone else in the waiting room or should we go ahead? Thanks for coming on camera. I love it. All right. Looks like we're going to be a nice tight knit bunch today. I love this because it can really be more of a conversation. So again, I'll welcome others on camera as well, or feel free to stay off. My name is Kameron Matthews. I am the Chief Health Officer with a company called Cityblock Health that I'm going to spend a little bit of time sharing with you guys, because I think there's a fair amount of interest about these kind of new disruptors out here, right? And I think we're very different, at least from what I was familiar with in healthcare prior to me coming on board. I'm a family physician by training, also an attorney, very interested in kind of larger perspectives within healthcare around advocacy and government. Prior to coming to Cityblock, I actually served as Chief Medical Officer of the Veterans Health Administration, where I helped really round out probably more the second and third waves of the pandemic and deploy our new internal managed care program called Community Care under the Mission Act of 2018. Well, actually, that was in my prior role before becoming CMO, but really had the honor, to be honest, to serve in the nation's largest integrated healthcare system. And for me, I said this in the last panel, this was a bit of a natural transition. And I say that with all jest, moving from the ultimate bureaucracy of running the VA health system to a startup. Extremely different. But the reason why I thought this would be so great, particularly from a transformational experience, from a clinical care experience, is that we actually have the same approach, which is whole person care. Not being really focused on productivity and the typical sort of structure that the rest of the healthcare healthcare system is really organized by, and really seeking to be innovative in that. And so coming from VA to the startup world, it's been an adjustment, but I actually feel that I gained enough of an appreciation of how a large health system could do it that now I'm kind of scaling it down a little bit. And I'll go into how big we are and everything, but I feel like still able to make the same impact. So let me go ahead and start slides. I'm going to really start off to introduce you really to how we were founded, how we really over the past 5 years have really struck out to carve a niche for us, but one that I think is necessary. Let me check with you, Ed. Can you see my slides?
I can.
Okay, good. So what I hope to convince you of, let me start with that, a problem statement / goal for today is to show you that I think in order to achieve the transformation that we need in primary care that we're talking about today through the National Center on Primary Care, we need to think outside the box. And I think that's what Cityblock Health is accomplishing, to be honest. So why do we need to think out of the box? Problem statement number one, the status quo is not working. And if we continue to spin our wheels and swirl with our traditional structures, our traditional payment systems, it will continue to yield the same results. I don't think we can question that any further. We continue to fail our communities, not just the individual people that are walking in the doors, but our communities as a whole, because the health system as a whole is not structured appropriately to make the largest impact to those who need it most, the most vulnerable. Even the way we kind of take our medical histories, the way I approach actually one of our patients in understanding their needs and understanding their disease processes and how they've interacted with the healthcare system only paints a partial picture. And then yet we love to describe them and really, I think, show them a great sense of disrespect about how they're interacting with our health system. How dare they question how we are providing them services? How dare we question or how dare they question our intent even. And so part of that is then acknowledging, and I think so many of us in primary care, this is our goal. This is why we got into this field in the first place. We need to acknowledge the whole person. We need to acknowledge the broader life that they live, the broader set of experiences, even down to that cat. And I'll bring that up again at the end. The cat ended up being like the linchpin with this young woman, about how we were able to connect with her, but just recognizing that so much of what we medically responded to was in no way sufficient to really address her needs, to think of her as a whole person. And so therefore, I see this as a systems issue, as we should, that we're not set up, even though it may be our best intent, it may be even how we're trained as primary care physicians. We are not able to respond to her needs because we're not addressing them. That's not what the medical model per se, and even our healthcare system is structured to do. And then you take that out of the individual patient realm and you're looking at it from a community standpoint, a neighborhood standpoint. We really are not able to respond to lower income communities in the best way. We're not able to really address the social factors that they are facing that are leading to their worst health outcomes, their increased utilization, their increased costs. It's something we note. We take that social history, right? We try to do as much as possible. We may sometimes in the larger health systems have access to a social worker or so, but it's not, it's not there. It's not to the fullest extent. We're left on our own as much as we would like to. We're left to identify these on our own, come up with action plans. And then oftentimes we just don't have the capacity, let alone the time, and sometimes that 15-minute appointment to address all of their needs, right? Communities can't mobilize. They don't necessarily have the partnerships. No one is incentivized in our current healthcare system to address this woman's needs. That's really my argument here. So what's our path to transformation? How do we get out of this cycle? I think we're in, unfortunately, as the pandemic has shown, a downward cycle. Disparities are worsening, not getting better, even with the awareness of them. And that is, in some spaces, half the argument, half the battle, right? That you need to recognize the problem in the first place. We know what the problem is, but yet we are still striving for the same solutions. So where does it start for us? Where does it start in Cityblock? It really was a concept of trust and engagement as being our starting point. You've seen this data. It's old. It's there. You can repeat it over and over, time and time again. It's not just the healthcare system. It's larger institutions as a whole tend not to hold on to the trust of the people that they are serving. Kind of cracks me up that Congress is even on there, but we are unfortunately, even though the patient-physician relationship, the patient-provider relationship is grounded in this, but yet it's sometimes not about your individual relationship, right? It's about the system as a whole, and we know the system is where we fail them. That's again what I'm trying to argue. The pandemic showed a light on this, a light that was ridiculously overdue, one that I think disgusts most of us with the fact that this was known and yet not accounted for in responses, but we won't get into the last administration. So what can we actually do about this? So we turn to a little startup. We are a startup. Cityblock is venture capital startup organization founded in 2017 by a couple of really strong players in really transformative healthcare space out of Massachusetts, where we really wanted to take a different approach to healthcare. And that is through a different type of financial model, to be honest. So when we say we are value-based, we accept up and downside risk for all lives that we serve. We partner with our payers, not directly. So there's no really direct member facing marketing, we take on cohorts of the most complicated with our payer partners, and we take on risk both up and downside. I can explain that if anybody here isn't really tracking what that means, in order to truly be able to finance a full end-to-end whole person plan of care for each member. We do this in an integrated way by offering primary care, behavioral health, and social services within our practice, and with what we wrap around. And I'll go into that phrase a little bit as well too. And we do this regardless of location. We're not stuck within walls. And in fact, most of the markets that we serve, most of the members that we serve, we see them at home for their primary care. We are not doing this in hubs. We are not doing this in clinics and offices. We're doing it at home. We're doing it virtually. And we are meeting them where they are. Our members, 70% of them are BIPOC. We have significant complex conditions. In fact, we pushed to take the more complicated members from the payers that we partner with. They have significant behavioral health diagnosis, as you know, in both the Medicaid and dual eligible spaces. You can't get away from that. We take that on with quite fervent sort of approach, because we know we can make a difference even with a minimal set of interventions. The problem so much is the average, I would say, fee-for-service sort of clinic isn't able to make the true impact from a trust and engagement standpoint to even get them into the practice to therefore then be able to do just the evidence-based care that we all know so well. So we're, our clinical care isn't different, but it's really how we approach the members in the first place. So we really take on a healthcare is local approach. We have community health partners that are truly there, understanding the community health workers. I mean, this is not a new model. I'm not saying, well, at least the community health partners part isn't. We call them partners because we see them as one-on-one. In fact, the linchpin of the care team. They are at the center, not us expensive physicians, but our community health partners are the main point of contact for our members. They are there to assess and intervene and address their social needs, provide some even health coaching, and to truly make sure they are the boots on the ground and understand the community and understanding where we should even be building out further engagement. Then we leverage data and technology. So one of the benefits of being VC supported is that we have a good bandwidth to really be innovative and explore and step outside of the box, because we know a lot of those off-the-shelf sort of products out there don't necessarily meet needs, right? Especially when you're trying to provide whole person care and not episodic sort of care. And then lastly, we take down walls. Like I mentioned, this is not about a hub. This is not about asking these members to come to us. We go to them whenever possible. We even provide the hybrid approach of ED at home, which is an emergency physician. I have a team of them that sits at home, and through an iPad, our EMTs go into the home and actually provide services. Obviously, when it's an actual ED and monitoring isn't necessary, but we also know that a lot of ED utilization can be done outside of the emergency department. So we of course call them and assess in the first place before sending them to 911. But if it is something we can manage in the home, we quickly send an EMT right to their door, and an emergency physician is actually on the other line. This is about trust. This is about really bringing down that power dynamic of having a care team that is not so physician focused, but really member centered. I think we say that a lot, but then how we're able to translate that, I hate to say this, in other business models, because is not unfortunately what comes to be, because you're often paid by the physician. So the team is physician centered, right? You're paid by physician visits, well, provider visits, not always physicians, I apologize. But, part of the concept here is that we have a model that allows us to really be transformative as part of the care team, and to really be able to not only bring on different care team members. I have pharmacists on our care teams. I have behavioral health. I have psychiatry on our care teams, social workers and the like. All of them obviously providing evidence-based care, but it's their interaction, it's their ability to surround the member, it's their ability to provide those services outside of traditional spaces that I think is really meeting the members where they are. So who do we work with? We have typical kind of archetypes of members that we take on as cohorts from our payers. We are purposefully taking those members that are facing significant social drivers of health, those who are undermanaged, those who have multiple complex conditions. We take on the SMI battles. We take on really those significant portions within our markets, those members who are typically not enrolled in primary care in the first place. That's often been one of the issues that I have with our entire healthcare system. It's great for those patients who know how to find us. It's great for those who can get into our walls. Whereas at the VA and at Cityblock, we have ownership of these members where they're walking in or not. Veterans are our responsibility at the VA, whether they are walking into our doors or not. So it is our responsibility to go find them. And I can't necessarily say we are in any way incentivized or paid to do that in other practices, right? So we're taking those SMI patients that we have to meet with on a park bench. We're taking those homeless patients, we're finding them, we're connecting with them, and we're establishing them in care. And then we are taking on and building out currently a significant portion of our palliative care work as well too. Some quick results around inpatient admissions, member engagement. This is some early data within our first couple of months within our first market in New York. We are doing as much as possible to really fulfill that triple aim of looking at experience and engagement, as well as quality outcomes, as well as cost of care. So our model does not work if we don't take down cost of care. But the understanding is that our incentives are aligned. Decreasing cost is not the opposite of good, high quality care. In fact, we know for a fact that overutilization actually results in worse outcomes. So cost itself is not only not a marker that we use to find our members, to really sort through the cohorts of who we're going to take responsibility of, but we look at it as a marker of quality. It's obviously not as important as clinical quality, but it is a marker of quality of the services that we provide, because we are we really do believe home services, prevention, the things that cost less result in better outcomes. And we as a health system need to flip that dynamic. That is part of the problem. So proud, I was able to sit as a fellow in the National Academy of Medicine and now as a member, was able to work with the high quality primary care consensus study that came out last May. Is it last May? Yeah, I guess 22, 21. Ooh, COVID blending everything. Dr. Steinberg is now thankfully implementing our recommendation that there needs to be some true government ownership and accountability with regard to how we're actually going to implement high quality primary care in this country. And I'm so glad that HHS, the White House, and HHS are taking this on. But the other recommendations are honestly something that I'm proud to say we are attacking in Cityblock, and that I think there's still barriers to the rest of the healthcare system to really do. That we are paying for teams, not individual doctor services. We are paid per member per month. So yes, the scary capitation model of the 80s, I agree. Everyone is fearful to go back to that. My dad's a family doc. He still cringes at the fact that I'm in a capitated model. But the idea is that capitation of the 80s was not as data driven. It was one fee per member. It didn't really have risk stratification involved. The technology and the data feeds weren't necessarily there to truly stratify and to have some actuarial planning around the cost of their members. That's what we do. So I have different negotiations for per risk stratification of my members. So I'm paid more for the patients that need more services. But the goal, of course, is to improve their quality, decrease their utilization, and we have control of that, not the payer. So it's truly the model that I think we were striving for in the 80s and that we clearly missed. We have designed and will continue to be innovative in the technology space. We have an internally grown care management system that is able to provide us really that longitudinal view of the member, and it is not just for the care team, but also for our it's for the care team, but not just for the clinical members of the care team, which the EHR is usually restricted to, but our community health workers are actually part of our care management system. How do we actually approach this? Just wanted to share some background from a business standpoint. We purposefully take on pretty substantial upside and downside risk, what everyone was so fearful of in the original views of macro, right? Because again, the average practice isn't situated, wouldn't necessarily have the support to get this off the ground. There's a lot of work though in this space to get primary care practices. You know, our friends over at Aledade are exactly in this space. How do you get a practice to the point of accepting the risk? Upside, of course, being the reward, downside being the penalty. We accept both sides and do take on the risk of perhaps these really expensive members that we haven't been able to make the impact on that we're striving for. We take on that risk and unfortunately have the financial impact there. But we do charge a per member per month fee that of course is data driven from an actuary standpoint. We have an internal team of actuaries that help us negotiate this and really work through the data in order to get there. And it is not about encounters. I mean, we still interact with our payers and we submit $0 claims so that they have the data, but they pay us in a separate arrangement. We are not paid by claims. So the data is critical. I still need my teams coding appropriately and all that different stuff, but that is not payment. That is not the source of payment. So really the value here comes from us changing our business model, our administrative model, in order to truly be able to support and resource the care teams with what they need. We're able to do this, as I've said, in multiple different modalities, whether it's virtual, in person, in the community, on that park bench, in the home, and our tech deployment is truly how we're able to do that, whether it's on an iPad or a laptop, or even by phone, by text message. We have huge text message campaigns to our members, and really looking to, of course, keep costs down and minimize our overhead through the traditional clinical practice. The other recommendations within the high quality primary care report was about assuring that our workforce and what services we're able to provide are meeting the needs of patients as well too. So does our workforce live and work and look like the members that we're serving? Yes. We purposefully hire our CHPs from the neighborhoods where our members are located. We purposefully have extremely diverse care teams, physicians, nurses, MAs, and the like. And the goal, again, is not only to have equity of outcomes, but equity and diversity of experience for our members as well as our staff. As we know, the many arguments around diversity of the workforce and how it actually impacts patient outcome, patient satisfaction is critical. And we are embodying that really every day in Cityblock and are really glad, so glad that we pulled this throughout the NAM report, because it just needs to be said over and over and over again that diversity and equity need to be the bottom line. We are, through our CHPs, appropriately assessing, screening, and acting upon the social needs of our members. So we are getting them housing. We are meeting their needs when they screen positive as far as food insecurity, transportation issues, family engagement. I mean, the idea is that the cost of the patient is clearly impacted by a lot of these social needs. The outcomes of the patient is even more clearly impacted by their social needs, but yet we're not able to usually make that true impact. A lot of times, at least at the FQHCs I worked at, yes, we had food banks we could refer them to. Yes, there was opportunity, but so much of it was on them to move forward with. Occasionally there's a social worker that, you know, correct them, and we love them, yes, every day. When you're looking at it at a population level, you know, we're not making that impact that we need to, right? And this is actually built into our care management system, how we're tracking these, how we're referring, what partnerships we have on a national as well as local basis. This is a major focus of our care team's efforts. And I kind of went into diversity and just the importance of those pieces within our workforce. All of this, of course, relating to how we need to transform primary care. So looking back to this member, you know, what would this have looked like? Those outcomes that we displayed from a medical standpoint earlier 42-year-old female, if you remember, significant asthma and other issues with her cat and everything. We really were able to reduce her utilization, improve her satisfaction and outcomes, find her permanent housing, make sure that she was actually on better long-acting asthma medications, even get her into that allergist for her cat. Her cat was a major source of quality of life. And our care team really took that on with significant focus. We were able to work with her in the home, and decrease her ED visits by sending people to her home with paramedic visits and the like. I mean, this is what we should be doing. This is a single anecdote of what happens at Cityblock on a daily basis. It's good primary care, but it's also, even more importantly, strong population health management. It's also really understanding that medical care alone is not necessarily, we need to look at really the well-being and larger healthcare of our members, and that includes social drivers of health. So with that, I might have gone a little fast. I don't even know what time it is. Actually, no, I think we're good. I'd love to open it up with questions, conversation, would love to tell you more. Thank you guys for joining. I love the small group.
Well, thank you, Dr. Matthews. I work with Dawn Tyus in the ATTC, and one of the, have you ever heard of the recovery-oriented systems of care? They did that. They worked. Well, they did it in Philadelphia, but it's along the same lines. I mean, it's one of those deals that the underlying Wesley Clark, who was the
General Wesley Clark?
No, he was no. This was Dr. Wesley Clark, who's head of the Center for Substance Abuse Treatment.
Love it.
He made the statement that it's not about getting somebody into treatment for their substance use disorder. It's about how do you support their recovery within their own community.
Thank you.
And so the whole deal, what excited me about this model is, again, it fits perfectly with what we know as far as the outcomes of supporting recovery capital, which is all of those things that y'all work on. It's sort of neat. I don't know if you ever, but it ties into it.
I'd love to learn more. I mean, even if you tell me the name of it, I should be reading.
It's Recovery Oriented Systems of Care, ROSC.
Got it.
William White and Ijama Achara did a lot of the work with it in Philadelphia and Connecticut. But it's one of those things that, prime example, I think it was in Northwest Philadelphia, but it was a shelter for folks that were experiencing homelessness, and they had a drug treatment program there. And one of the things that somebody figured out, that the women in the treatment program were really good cooks, and got them into working in the kitchen. They didn't kick them out of treatment if they tested positive. And what they noticed was the women started getting longer and longer and longer periods where they were abstinent from illicit substances, because you were building on their strengths and providing hope, and they began to see that my life can get better. But I get real, I mean, it was a thing. I was at a conference, and it was somebody from Magellan Health in Nebraska talking about, about what they did with cell phones?
I have heard of it. Yes. We were looking at something similar in the VA.
Yes. I mean, because it was like, and I mean, of course, talking to people from the substance use disorder treatment arena, that some of whom really should have retired quite some time ago. So how many of those were stolen? It's actually only 2 out of 100 were diverted. But this whole concept of treating, it's like, and I don't know what your experience is, but it's so challenging to get medical schools to include treatment or include a basic understanding of addiction.
Yeah.
that it's
Oh,
not.
it's overwhelming. I couldn't agree with you more. I think we're overdue for more than just a kind of reconsideration of medical education in the health equity space, right? I think how we approach behavioral health and psychology and addiction and treatment is something that is just completely not supported well. I am really proud that we're building out kind of home-based psychiatry and behavioral health services in general in Cityblock. We're going to be, I mentioned in the last panel, we're going to start sending our EMTs into the homes to provide long-acting injectables and MAT, and we're just going to start initiating in the home. Why does it need to be in a clinic? We can sit there and monitor. We can, I mean, it's these people need more options.
Yes.
And we're hoping to give it to them.
That's down here and I'm even though I work for the ATTC, the Southeast ACTC, I tell people I'm the most remote employee of Morehouse School of Medicine because I'm over in Charleston.
Great.
And but the Department of Mental Health and Alcohol and Drug we're the only state, two completely separate entities. Mm-hmm. But they used to have something called assertive community treatment. And it was a whole team. And a lot of it, I mean, most of them got whacked in 2008 because they required a lot of assets but it was, again, going into the homes to meet people, long-acting shots. And it was one of those deals, again, it kept folks out of the emergency department.
Yep.
And
yeah, that's the whole goal. So we have, I mean, it's very typical in the health plan space, not something that provider organizations tend to stand up, but I have a whole department that I'm going to be expanding on transitions of care. So it's not just left to the longitudinal teams to fit it into their day-to-day sort of, I mean, think about it. In a typical practice, they're focused on kind of productivity. So if that patient discharged from the hospital isn't in one of their visits, it's hard to squeeze them in. Yes, we have same-day services and everything, but it's a lot to manage. There's medication reconciliation, there's education and the like. And we know those hospital discharges are just as hard as like the new patient coming in with no medical record, right? There's so much we got to do. So we actually have a separate standing transitions of care team in every market, led by an unbelievable TOC doc that I have and a care management team, where their whole goal is to know when the patients get admitted, either inpatient or ED, visit them if possible while they're still there, communicate with the teams to know when they're getting discharged, what the discharge plan is, if they're going to a SNF, how we can actually communicate with the SNF, follow up. Right now, by regulation, by 7 days, but we're going to start increasing that and get to 48 days, a follow-up visit in the home to make sure that they have their meds and their reconciliation, to make sure they have the education to get them transitioned back to their longitudinal care provider. We have a team dedicated to that in every market. And part of that is to prevent that readmission. Part of that is to get them enrolled into care, because remember, we take assignment of members whether or not they've walked into the door. A lot of times they don't even know that they're a Cityblock member. So as soon as we learn that they're admitted, we go and try to get them into our system. So it's also an enrollment path for us as well too, that they've walked into an ED, that they've been admitted to the hospital, a lot of them into behavioral health hospitals. And so we go in there and we get them enrolled into our care as well too. So part of this is where we have the teams in place because we've learned so much from the health plan side of the world. We're like part health plan, part provider, right? Because we're taking on that risk. So we need to manage a lot of what is their responsibility as opposed to the typical provider organization. But from that, I'm able to really assess and see, actually, let's tweak this to an actual service we're providing, as opposed to just checking a box. Oh, we saw them within 7 days. It's actually something to prevent readmissions, because most of the health plan work, there's absolutely no evidence that it impacts outcomes. It's just something they do. So we're actually turning it on its head.
Which, of course, with 99% of addiction treatment, it's the same way.
There we go.
It's like, I use the analogy in trainings of, it's like if a primary care physician gave somebody medication for high blood pressure and then waited until they showed up at the emergency room with a stroke to realize the medication wasn't working. And that's what we do in addiction treatment. And in case my peers haven't noticed, I have verbal diarrhea. And so I don't want to take up the whole conversation. And I'm drinking decaf. I swear to God, it's decaf.
I love it. You're good. No, thank you, Ed. Kristen, is there anything I can answer for you or whatever? This is like a fun opportunity. I was like, sure, I'll come talk about Cityblock. Anything I can address for you or even give me some ideas?
Absolutely. This is so wonderful. And it's also nice to see you again. I saw you at AMEC.
Oh, good.
And I was like, oh my gosh, she's so amazing. I want to have a career like her one day.
I love that. Thank you.
So this was really nice. I didn't actually know about Cityblock before. I'm going to be an intern, internal medicine, primary care track. So incoming intern. So this is really interesting for me.
All right. Call me in 3 years. Let's go. I'm going to need you. I'm going to need you. Yeah. No, what I think is another part of disservice of medical education in general. And, trust me, we've all been through it. Is that there's not enough awareness of other options outside of academia. Like because you're trained in this space, you're trained by academicians, and while of course there's honorable people there doing, God's work and everything, it may not lead to models like mine. It may, and my whole career was really serendipitous. Like, I can't believe after residency, I wound up at Cook County Jail on the west side of Chicago. My second year of residency, I did a month at the jail that I absolutely loved. I felt it was 100% health equity work. 90% of my patients, were Black and brown males. And they offered me a job. I was like, hell yeah, this is where my first attending job. I want to learn this. I want to understand this. I want to understand justice. Right. And so then after that, my first FQHC, then my second FQHC, then the VA, and now Cityblock. And so all of that non-traditional roots, if everybody in academia is like, what is she doing? But, part of this is I wanted to make the impact. I wanted to find the populations that needed me most. So I knew I was never going to be in academia, as a job. I was on faculty, don't get me wrong. I've got publications. I'm in the National Academy of Medicine. I'm there. But, part of the goal was to do that by really stepping outside of the box. And there's so many ways you can do that. So look us up, look up other things. We all need you because our patients need you more than anything. So thanks for doing what you're doing.
Thank you so much. I actually had a question, and I think you kind of already answered it when you said that some patients don't even know that they're Cityblock patients.
Yeah.
So how do patients, I guess they do not elect to join Cityblock, and once they're already enrolled with you, how much participation do you typically get? Do they are like more receptive to like your reach out or not?
Yeah. It's a good question. So we are assigned our members by our payers. So our contracts aren't with the state, our contracts are with the health insurance companies that then assign us members, usually the ones that they have difficulty managing. And that's who we want anyway, right? So we're paid per member per month of the ones that they are assigned to us. And we take risk for all of those that are assigned to us. Then it's up to us to engage with them. So yes, we actually have an unfortunate proportion of those members that are assigned to us that don't engage with us. They don't answer our phone calls. We haven't been able to find them. And we are still at full financial risk for them. So that's what completely incentivized us to go knock on the door. I actually have a couple of members. We have done outreach 45 times. Like, we just won't stop because we are responsible for them and we are going to go find them, right? That's why I have people who are on the benches looking at every individual here in DC, going from bench to bench, finding people that we heard live there. And so part of what we're able to do in having that restricted cohort and not being kind of this open-ended enrollment is that we're able to take that ownership. We are working on different engagement measures. And so we consent them to actually come to our services, and then we start them kind of in our engagement process with their clinical care team. We're improving that. Even over the past couple of months, our numbers have shot up, but this is the reason why the payers pay us. That's why they contract with us, because we're doing things that they, as health plans and their traditional providers in their network, can't do. So we're finding the members, we're bringing them into services, because we're not bringing them in, we're taking them to them. I mean, that's part of the model. Yeah.
And are they Medicaid, Medicare, or this is completely private insurance?
Actually, minimal private insurance. I have 2 states right now with commercial plans. It's actually Medicaid and then dual eligible. So dual eligible is Medicaid and Medicare. So it's all low income. It's all government program, with the exception, we took some early commercial contracts just to see how that works. I mean, it's a different population. And then within the dual eligible programs, we take the most complex. So I'm not sure if you're familiar with DSNP, dual eligible skilled something, I always forget what. So there's all these lines of business, they're called, in the CMS world, that leads to levels of complication and requirements of care management and services and everything. SSI as well too. We take all of those lines of business where everybody else is like, oh, that's so much. Like, we take them on purposefully.
Real quick question,
Yeah.
Dr. Matthews, is for like the patients that
Yeah.
have multiple chronic problems, do y'all, I know you mentioned capitated rate, does Medicaid and Medicare provide you more of a
Capitated rate?
Yeah, for those folks? And so with the expectation that, I mean, this is sort of like, you know, what never got talked about with the Affordable Care Act was its emphasis on prevention. And all, and then all the insurance for pay insurance companies, oh no, we're losing money. Well, of course you're going to lose money the first several years. But so that's what I figured, but I just want
to so no, we're not, let me correct that though. We're not paid a different rate by CMS, because our relationship is not with CMS. Our relationship is with the health insurance company. So for instance, Emblem Health is who we contract with in New York. Emblem has the contract for the DSNP population, which is a higher complexity and therefore higher paid group from CMS and state Medicaid, because, you know, Medicaid, the dual eligible programs are run by both federal and state, because they're both in Medicaid and Medicare. So Emblem has the contract, gets paid a certain rate. We negotiate and contract with Emblem saying we will improve your cost of care and therefore improve your savings on your rates with CMS if you pay us a certain proportion of the incentive. That's how our model works.
Which, I mean, you know, it's one of those deals that I've always strongly felt. It's like, you know, there's nothing wrong with earning a profit in healthcare, but sometimes the profits can be a bit obscene. And the services and the services really lacking.
Exactly.
And that's one, don't get Ed started.
But I mean, you know, and I think part of it is why we need to be a provider organization making these decisions about what services the members receive, right? I'm directing that as chief health officer, right? And so, yes, it's about decreasing cost of care. Trust me, I have a board of directors. You know, our finances are looked at, you know, and I'm constantly being asked, but it's not in lieu of quality care. It's with the assumption that there is excess utilization. So how do we bring that down, right? We know for a fact we're not efficient in our industry. So it's not really about having a gatekeeper saying, no, you can't have that care. It's about what services can I build out to replace or completely prevent the really expensive services. Case in point, our members don't utilize primary care at a very high rate. They're going into the emergency department for a sore throat. If I can just prevent a handful of those admissions, I just made some money because I just saved a whole bunch of costs. You see what I'm saying? So and that's better quality of care. They don't need to go into an ED for a sore throat, right? I mean, there's other nosocomial things they could be exposing themselves to, particularly over the pandemic, right? So part of this is about aligning the incentives that decrease cost is really about decreasing unnecessarily utilization, which is actually about high quality of care. And so our incentives are aligned versus the rest of the system. I actually need to incentivize more utilization because that's how I get paid, because that's what the fee for service model is, right? Hospitals aren't incentivized to keep people out of the door. And that's the problem. So anyway, I think we are now, oh, I'm sorry. Kristen, looked like you had a question. What's up?
Oh, I was just wondering, because you mentioned that you still have people who code. What is the administrative cost like? And do you feel like that dampens down on the actual clinical portion you can provide?
So we have some rather large administrative costs as well. I think we could do better there. Part of it though isn't like my coding team. Coding team is minimal. It's actually because we also create so much technology in-house. I've got a large digital and product team. Like when I'm talking like Silicon Valley sort of type people, I got all those in Cityblock as well too. So it's not your typical IT department that's just managing things. I've got the innovators who are trying to bring us new efficiencies through our products and eventually maybe even spin it off and sell one. I mean, that's the other thing. We're in a startup. We got to make some money for our board. We got to create something that works so that we can sell it too. And so again, it's incentivized. I can create a product that works for my patients because there will be a market for it. Yeah.
So cool.
Yeah, I like it. I
It's
can't believe
so cool.
I'm still like, oh my God, I'm here.
That's when I first found out about recovery-oriented systems of care. Yeah. I saw this slide, and I mean, I'd worked in the field doing direct services for 20 years before I got here, and came from a 12-step background of, well, they don't want it bad enough. Guess they haven't hurt bad enough. And it was a quote on this picture of somebody who was obviously not doing well. And it was from a social worker. And she said, my patients don't need to experience more pain or loss. If they experience more pain or loss, they're going to die. What they need is hope. Mm-hmm. And it's like, bingo, bango, bongo. Yeah. There you go. That's
we have to transform systems. And we're not going to do it one patient at a time. And I think that in and of itself is a great example that you just change the perspective of how you're approaching patients as a whole. Yeah. All right, guys, I think our session is done. Thank you so much.
Thank you
for joining. Enjoy the rest of the symposium, guys. Bye-bye.
Bye.